Okay, so today, I am mostly covering the analytic approaches, but also some of the more conceptual topics in terms of picking performance measures as well. And I want to acknowledge Deb Rosenberg, who is a longtime faculty member who put together some of these slides, and also Jessie Lickstein, my colleague at the Maternal and Child Health Bureau, who is our performance measurement officer. And so she's a great resource if you do have any questions about kind of selecting and developing performance measures. I would say I'm more of the quantitative in terms of setting targets. But yeah, let's get started. So what I'm going to be covering is a little bit on the purpose and definition of performance measurement, and then going through the phases of performance measurement. And those are listed here. We'll go into those in greater detail. And I'll try to highlight some examples from federal programs, federal state like Title V, as well as Healthy People. As you know, I'm sure you've all used Healthy People to look at their objectives and targets. So here's kind of a basic quote, really emphasizing the importance and why we do performance measurement. It's really helpful to clarify your goals, examine your progress toward achieving those goals, and really documenting the benefits received from programs. So it's really for accountability. So what is performance measurement? It's the regular collection of data to assess whether the correct processes are being performed and desired results are being achieved. So the questions it can answer is, what is a program doing? How well is it doing? Doing it, is progress being made towards your desired goals? What it's not, it doesn't tell you if your program is directly producing the results or making an impact. That's what evaluation does. And it doesn't provide small scale data collection for rapid cycle feedback and improvements. That's what QI does. And so here's a little table that kind of helps you distinguish and look at kind of the intersection of these key concepts of performance measurement, evaluation, and quality improvement. So really the performance measure is focused on accountability, whereas evaluation is really causality, and quality improvement, of course, is the small tests of change for improvement. And so the data timing occurs at different periods. So there's regular reporting for performance measurement. Quality improvement is more that rapid cycle, maybe quarterly data. And then the control group is really the distinction for evaluation to really get at that causality. So the steps of performance measurement I have listed here, and key tools as part of that we'll be kind of going through. So the first step is really to clarify your program goals and priorities. And you can do that through needs assessment, project models, and both of those will come up even more later in the course. Needs assessment on Friday. And then Pat, I think, will be covering logic models. Then from these goals and priorities, you then select and develop measures. And you can use standardized criteria, results-based accountability. Those are different kind of approaches and frameworks to assist in developing and selecting measures. And then once you have the measures, then it's setting improvement targets and objectives. And you may have decision rules or analytic techniques to help you set those targets. And then you just need to track your progress. So that's monitoring your data, and you can evaluate or examine those changes over time in your progress through certain analytic techniques like progress quotients, as well as summarizing that progress in tables and graphs. So I have a poll, Ashley, if you can add this now, in terms of which phases of performance measures you all have participated in. You can go and check all that apply. Ashley, does it look like there's a key quorum in terms of completion?
I will give just a couple more seconds and then, okay, we're
Okay, so tracking progress was clearly the most common, and that's not unexpected. I think most of us end up tracking progress, perhaps for other targets and measures that others selected as epidemiologists. And I think we really hope that we are at the table in terms of helping to identify priorities through the needs assessment and selecting developing measures and setting those targets and objectives. So hopefully those who have that experience can weigh in as we talk about the different approaches and share your perspective. That would be really helpful. So the next one is just, which do you find most challenging?
okay. You should be able to see the results.
I don't see them, but okay, there they are.
There they are.
So selecting and developing measures is, most of you say that that is the most challenging. And I would agree. I think that there's some really thorny issues in terms of selecting measures that matter and that are available. Those two don't always align. I think there's also some challenges, I think, in determining how you set objectives and targets, and we'll talk about that. And yeah, tracking progress, I think, is the easiest part. All right, so the first step in clarifying goals, it's really important because we are really answering questions about a program. Are we doing what we said we're going to do? How well are we doing it? And are we achieving desired results? So this means before we talk about the measures, we have to determine what the program is supposed to do, how and when the program is supposed to do it, and what success or achievement looks like. So logic models come in really handy in terms of the development of performance measures. they're a visual representation of the theory of change for a program and how the program is intended to work to achieve those goals. So you have, this linear process here, your resources and inputs, your activities, your outputs, outcomes, and then impact. And you can also look at this through the evaluation framework here. So you're starting with your planning goals and priorities, and you have your process inputs and outputs that measure implementation. Am I doing the things right? And then your ultimate outcomes, the effect of your effort. Am I doing the right things? That's kind of the question you can ask. So if you're not seeing the desired results, it may be time to try a new strategy or look at your fidelity to the strategy and process. So here's some just under this examples of these process inputs and outputs. So inputs might be things like materials, staff, time, funding, and outputs that you can measure might be trainings, policies, education, treatments, for example. And then for outcomes, there's just kind of medium-term outcomes and then ultimate impact. That's really those core health, morbidity, mortality measures. So selecting and developing measures. Again, there's these two main types of measures, these structure process measures that measure the implementation of the program or strategy. So these are organizational structures like staffing and resources, and processes like the different services that may have been delivered. And then the impact or outcome measures really measure the results of these structures and processes. So here's a little poll. What type of measure is this? The percent of very low birth weight infants born in hospitals with a level 3 NICU. Are we still waiting? Okay. Interesting. So 28% said structure process and 72% said outcome. And there may be different ways of thinking of this, but for those who said outcome, can somebody chime in and say what they were thinking in terms of why that would be an outcome?
Feel free to unmute or utilize the chat.
Bonus points for participation.
Okay, I'm going to be brave here. I thought this was an outcome measure because I was thinking that there'd probably be an intervention that's trying to reduce the proportion of very low birth weight infants. So there's an intervention, and then the outcome is seeing if there was a reduction in very low birth weight infants.
Mm-hmm.
But now I don't know if that's right.
Yeah, I mean, I think there are different ways of viewing it. So outcome is more the intended results. And so if you were parsing it out into that in terms of an intervention that was really designed just to do that, it could be viewed as an outcome. I think this is really how we kind of think of this in the field is more so that this reflects a system of care. And so it can also be thought of as a structural measure. So this is kind of measuring how well that system is working, to say the percent of, infants, high-risk infants that were successfully delivered in a high-risk facility. So I think that there's probably different ways of viewing it, but if you wanted to further go out into an outcome in terms of health and morbidity, mortality, I think you would be kind of then looking at infant mortality, so very low birth weight mortality. You would hope at the state level that would be decreasing as a result of this structure. And there's a couple of comments here, kind of echoing some of that.
Ashley, is it okay if I chime
Yeah.
in here just a little bit as you're reading through the comments? So just some folks may not be familiar with perinatal regionalization systems, right? So so if you're not familiar with that, I think it would be hard to understand how this is a structure, process, outcome. So in many states, or in some states, they have an official system. Some states have kind of an unofficial system. But there's a system called a regionalized system of perinatal care, where the hospitals in a region work together to try to ensure that high-risk pregnancies are delivered at hospitals with level 3 or greater NICUs. So they set up systems of transportation and contracts and all of these things. So it's a system of care to try to ensure that these high-risk babies are born at a place where they can immediately go to a NICU if they need to. And so that's why this percent of very low birth weight babies, right? That's kind of a proxy for a high-risk birth, or a very high-risk birth, makes a good structure or process measure for this system of care, right? So, this is kind of indicating, is this system working the way it should? If almost all of the very low birth weight births are born in one of these regional centers with a level 3 or level 4 NICU, then this system is working the way it should, and that should result in an outcome where these high-risk babies have better survival.
Yeah, thanks, Mike. I did not provide that context and kind of took that for granted. But I think it still stands that you could view it kind of as a continuum, that it may be an outcome for a strategy.
Yeah.
And so there are these layers of measurements, and we'll see, how that works. But technically, it would be more capturing the success of the system and the structure of the system. Which, yeah, I mean, like we've said, it could be, you could view it kind of either way. And then I did see Ibitola had a question about these Title V block grant measures are usually viewed as and expressed as a percent or ratio rather than desired change as seen in research. And so that's an important distinction I think we'll get into in a bit, but the measure is just the measure itself. When you set improvement objectives is when you would frame it as such. And it may be a little bit confusing because healthy people kind of list their measures as objectives. But yeah. All right, let's move on. So here's some common criteria for performance measure selection. I call it the 3 M's, meaningful, measurable, movable. So is it relevant to stakeholders and agency priorities? Does it capture burden, costs, increasing needs, trends or disparities? Is there room for improvement? Measurable, of course, are the data available? And again, this ends up having like an iterative process. You might think you need a measure that is ideal, but then you don't have the data, so you kind of have to work backwards. And I think a general principle for that kind of conundrum is to really measure what you can measure well, and kind of accept what you can't. And having the wisdom to know the difference. And then movable is progress attainable with available knowledge, and is it feasible and realistic within a defined time period. Here are the 9 criteria for healthy people 2020 objectives. I don't need to read these aloud, but I think I'm just giving a flavor for different criteria used. And, you know, as you set up in your states or programs or localities, your criteria, I think it's just good to have that explicitly stated. And these just may be some helpful frameworks to draw from. I think on Friday, Bill will talk about some of the criteria for criteria-based needs assessment, which is kind of similar to this. And then for Healthy People 2030, just an update. What they did is basically dramatically simplified the number of objectives from over 1,000 to 355. And they realized that they needed to help prioritize the most pressing public health issues. There were just like too many to kind of get a handle on. We really need to focus efforts. And that's an iterative process. Like you learn through these different generations of measurement, and can use that to update your approach. Here's the National Quality Forum, some of their measure evaluation criteria. Again, it's capturing some of these meaningful, measurable concepts, as well as feasibility and usability. They also kind of look at related and competing measures to ensure harmonization. And just a note on directionality. So a lot of measures and objectives can be framed negatively or positively. So for example, you could be aiming to reduce obesity or positively improving healthy weight. And it's really kind of a philosophical choice. It's easier for percentages than for rates. So infant mortality, it's hard to say like infant survival and then capture that, which would be like 99 per 1,000. It would be, yeah, like 999 per 1,000 survival. It would really be hard to see that. But I included here as an example, this HOPE initiative, Health Opportunity and Equity Initiative. And they did use infant mortality, but then were able to describe it their goals in a positive way. So calculating that number that would be needed to prevent to get to equity. So that's just subtracting the national rate from their HOPE goal, and then multiplying that by the births per thousand. So they're saying we need over 13,000 more infants surviving to their first birthday to achieve that goal. And I really like this initiative. I think it's RWJ funded. And they explicitly say this opportunity framing provides an asset-based orientation to replace more of a deficit-based orientation. And it can highlight achievements and opportunities for improvement. So they say we measure income, not poverty, employment, not unemployment, housing quality, not housing problems. And they really do, look at a lot of those social determinants of health. It's a good resource that's designed for the state level if you wanted to check that out. So here's an applied example from the Title V performance measurement framework. And here's our logic model. So at the heart of this, we have these national performance measures, which are these short and medium term outcomes. And these are usually kind of healthcare access, quality, behavior measures that then feed into these national outcome measures, the longer term ultimate outcomes of morbidity, wellness, and mortality. I'm sorry, I feel like I need to go get some water. And then these on the left-hand side are these process measures. So they encompass the strategies that states are taking to achieve movement in the performance measures and ultimately the outcome measures. So this is kind of a worked example where we would have these evidence-based informed strategies, and improvements in those would lead to improvements in behavior that would ultimately lead to improvements in sudden unexpected infant deaths. So improving the safe sleep environment to achieve that. These are just some of the criteria we had for selecting national outcome measures. And just something to note here, there were some that were not actually ultimate outcomes. There were some that were just mandated by Title V legislation that we kind of had to put in there, like early prenatal care, or I think substance affected newborns. And then there are also opportunities here where you might include an outcome measure that's just important to track, but we don't yet have evidence-based interventions to address them. So autism is kind of an example of that. And Healthy People calls those developmental or research objectives. This is just a list of those outcome measures and sources. For the performance measures themselves, these were really designed to be those that could be more immediately modifiable by Title V activities, that may have had a large investment of resources, that had room for improvement, and that were associated with one of our national outcome measures. And so here's an example here. And again, that risk appropriate perinatal care that we talked about before, that is one of the Title V measures. And here we are kind of calling it an intermediate outcome, even though it really is more of a structural indicator with a morbidity, mortality outcome. So the evidence-based informed strategy measures, these are really the hardest thing for me at least. I think I tend to think of more of the quantitative measures, the health measures, and these process measures. I don't know that most of us trained in epidemiology were trained in this kind of development. They really are important though, and it's really helpful to take a data-driven approach and to help our programs in developing these. So they're the real key to understanding and demonstrating the impact of our program. And the steps here are really to select a meaningful strategy, operationalize that strategy as a measure, and then set improvement objectives. So here's a checklist that we have in our guidance that might be helpful for these structural process measures that are like the ESMs. So here, like some important concepts to check off for determining if it's meaningful. So is it evidence-based? You can consult the evidence. If the strategy, you obviously want that to be related to your state priorities, and involve stakeholder input and have potential for improvement. Yeah, these are kind of like basic principles here. The strategy output is measurable. So we're really looking for being able to quantify that as a number, percent, rate, count. We really do recommend the quantitative measures over those qualitative yes, no, just so that you can show incremental improvement over time. Like a yes, no is just, I did it and done. You can't really, you can only show one change over time. And so to really connect it to movement in a performance measure, it's great to be able to track multiple changes over time. And we can talk about more how you might do that. So here's a framework, results-based accountability, that some of you might be familiar with, that can help you in really looking at these structural process measures and intermediate outcomes. So they have these kind of 4 categories of measurement. So on the top row is effort and kind of what you're putting into it. So that's kind of the process and structure measures. So the quantity of what you did. And then they call this quality. I think that those terms are confusing, but it's really just adding a denominator so that you know that your reach. So yeah, you might have disseminated however many flyers, but as a proportion, how much of the population did you reach? And so really we do want to mostly move towards these reach measures that do add a denominator. And then in terms of the effect, that's really some of these outcome kind of measures. So what was the effect of a training that you might have done? Were individuals better off in terms of improving their knowledge, attitudes, and behaviors? And I think that, I mean, some of this, they tend to recommend like moving down from 1 to 2, 3, 4. But I really think that 2 and 4 are really important to have both, because you could have an effective strategy, but you're not reaching much of the population, then you're not going to have an overall population effect. So I think both of those are really important to capture. So here's just some examples if you were using that RBEA framework. So if the strategy was, partnering with a program to increase safe sleep education and counseling, maybe your effort and quantity might be the number of parents counseled, and then the quality or really the percent reached would be adding that denominator, the percent of the target population reached, and then really focusing on whether that was effective, the percent of parents that changed their knowledge and practice as a result. And outreach to hospitals to implement safe sleep protocols. So you could first assess like the number of hospitals with a policy as a proportion of all policies, you know, to see how far you have to go to get to 100%. And then really looking at providers maybe that changed their practice in those hospitals. So some of this does require that data collection that may not be available. Common issues here for our ESNs in particular is, you know, selecting strategies that are not evidence-based or directly related to the performance measure. So maybe improving the content or quality of a well-woman visit instead of access to care and utilization, for example, through insurance or reminder recall efforts to kind of promote utilization. The measure not being quantitative, so having these yes/no measures like we talked about, having a count without a denominator, so lacking that context, assessing effectiveness without reach, kind of already talked about that, and then the scope or size. So sometimes the ESNs are too narrow or too broad to show progress over multiple years within the 5-year cycle. So there could be activities toward a broader strategy. And so you might be like doing an activity and say, okay, we did it, and then we'll do another one, but then we can't assess that overall intent of the strategy over the full period. Or it could be a really ambitious policy change that might not happen over that 5-year cycle. And so it's really kind of picking out what's the intent of that policy and how can we, you know, quantify progress towards that intent. So here's some examples that we can talk about here. To make these strategies more quantifiable or achievable. So developing a public reporting system of low risk cesarean by hospital. That's really the strategy. Does anyone want to take a step at thinking of possible measures that would go along with that? Okay, there's one in the chat. So publish a report card, yeah, so that's kind of the strategy. So the measure would be like, in order to avoid that yes or no, like just publish it, it might be to look at how many views of the report card. So to track the number of views to a dashboard or a report card. Yeah, and so that's connected to a performance measure, which is the low risk cesarean. So that's really, you know, kind of looking at public awareness, and it could be getting hospitals to buy into it and participate. So maybe the percent of hospitals that participate in this system, or like I said, the number or reach in terms of viewership of a system. So how is it being used? How about working with Medicaid to ensure comprehensive coverage for smoking cessation treatments. Any ideas for how to make that quantifiable as a strategy? Measure. Okay. Nice. Okay. Thank you, Jessica. Percent of services reimbursable by Medicaid. That's a good one. So you could basically say, okay, what are the number of different cessation treatments and what proportion of them are covered by Medicaid, and track that over time. That's a really nice one. Thank you for participating. So this is just kind of a slide that shows the HP process and kind of vis-a-vis our Title V framework. So they just use a little bit different terminology, but they have this like overarching vision to reduce infant mortality would be kind of our parallel for Title V with these outcome measures. And then they have goal statements. So to increase safe sleep behaviors, and that informs the selection of measures. And the actual measure would be the percent of infants placed to sleep on their backs. And then from there, you can develop strategies, establish baseline and set targets for SMART objectives. So those are those specific, measurable, achievable, realistic, and time bound. I think that's it. Okay, so now we'll get into more of the analytic approaches, the target setting. And I don't know if this is a good time to take a break since there's only two sections left. I saw a nod. So let's take what do you guys normally do? 5 to 10 or?
We
Yeah, go ahead.
I was gonna say about 5-minute break, probably.
Yeah, we could just say to meet at the top of the hour.
Okay, yep.
So that would be
7 minutes.
I know we're all in different time zones. It's noon for me, 3 p.m. Eastern.
Okay. We will take a brief break and just come back at the top of the hour. Refuel on water, tea, coffee, anything you need.
Okay. It's lunchtime in my household, so I apologize if there's some children's noise. Okay, so now we're going to go into the data part in terms of setting targets. Oh, let me present the screen. So some considerations that may be helpful kind of in determining how conservative or aspirational you want the targets to be. So how will success be defined? Meeting a target or making progress toward a target? How will the targets be linked to the effort? Will they reflect kind of past current effort or influence effort? So you might want to set an ambitious target to really motivate action. And then, yeah, are there consequences for not meeting a target? And normally for performance measurement, there really aren't. unless, yeah, I'm trying to think of like accountable care organizations that have like pay for performance systems, where that's definitely incentivized and motivated to have that improvement. But for most of our public health programs, they're really, there's no harm in not meeting a target. So the target setting approach might vary, depending on a lot of different factors, like the type of indicator, process, or outcome. Maybe you feel like you could make larger impact on your processes than the ultimate outcomes that might be influenced by a lot of other factors. Whether external recommendations or best practices exist. So whether you might have a benchmark or kind of knowledge of the effect of a program you're implementing, that could really make it more data driven. How far you are from a goal, you might want to be more ambitious to try to get to that. Looking at the values and trends to see kind of where you've been and kind of projecting that out. If you haven't seen an improvement at all, you won't be able to set a projection. And so that's something we'll be talking about shortly. Factors that mitigate for or against improving performance. So maybe like external factors for an issue. Maybe there was a policy change that would affect kind of movement in an indicator in one way or another that you might want to factor into that. Who the program reaches, if it's population wide or if it's designed for specific high-risk groups, where maybe you'd have more success if it's targeted. How much control the health agency has over the indicator, and kind of what other activities are addressing a particular issue, which I think is kind of similar to other number 5. Okay, so different approaches for setting targets. You could use the projected level of an indicator based on continuation of the trend over time, or altering that trend to reflect the effect, projected effect of your program, or just saying that you want to kind of bend the curve and do more than what would be expected from just pre-existing trends. You could use a fixed number or value. So maybe there is a goal or standard like healthy people that you would want to meet. Use an absolute or relative percentage change. Use a value representing a statistically significant change. Use the best stratum. So if you looked at different demographic groups and kind of picked the best and wanted to get everyone to that level. And using total coverage or elimination. So maybe you're really close to achieving the target of 100%. And so you just set that as the goal. Or you could use the current indicator level if you are already satisfied and want to maintain kind of that level. Oh, I'm sorry. Got out of presentation. So which target setting methods do you most commonly use in your work? So this is another poll for you all. Okay, so there's definitely a range of what folks use. And that makes sense because the same approach is not going to be used for every measure, and we'll see some examples of that. But yeah, fixed goal is interesting. Maybe people do use the healthy people, but I'm just wondering if anyone wants to chime in and talk about what their kind of fixed goal or standard is that they use. Please feel free to do so. I would like to know. Or chat it in.
And this is Bitola from Tennessee. And with the MCH Block grant, we work towards a fixed goal that we would assess at the end of every year. So things relating to injury in youth and children.
Okay, I think, yeah, there are interim goals, and we'll talk about that in terms of showing what that indicator would be based on your method. It looks like in the chat, there's a lot of people who do use healthy people. I think the problem is that what if you've already achieved that goal? What would you do? And yeah, we'll look at some of the options. Okay, so here's the example with trend projection. So here's just some like example data. Really, this has 5 years of data to set the next 5-year objectives and targets, and that's really what Title V does. So this is for a given state. Their baseline is 64.2%. How would we do the projection? This is really, there's ways that you could do either a linear approach, so looking at differences. So that's just that linear slope. And I don't know how far Mike has gone into some of the statistics, but that will come up later, I think, in regression. So this average annual percentage change is really like a log linear slope. And that's generally recommended for trend analysis, particularly for rates. So it's a relative percent change instead of an absolute change. And so this is kind of like the poor man's approach to doing this. You really could use regression, and I'll show a resource for you to be able to do that. But in a very simple way, on this slide, you can basically calculate the each consecutive percentage change and then average them for an average annual percentage change. So here in this table, I have put in the annual percentage changes, but one is missing. If you all want to take a stab at that calculation, I'll give you a minute or so to do that. So it's comparing 66.2 to 57.7. And feel free to type it into the chat. Oh, well, I just showed it and somebody got it. Okay. A bunch of you got it. Good. That's great. So you all are going to be great on, I think, Michael Kramer's lecture too on absolute and relative measures. You already got this down, relative percentage change. So that's good. So, I mean, that's kind of how you would calculate it, that difference divided by the baseline. And so that's 14.6%. So there was a big jump on a relative scale that year. So then calculating the overall average annual percentage change, you all know how to do an average. So it's just, you know, taking those 4 individual year changes, dividing by 4. So that average annual percentage change is 4.3%. And so the 5-year target would be, you know, taking that baseline and multiplying by that 1 plus the percentage change to the number of years that you're taking it out. So that's 5 in this case. So you come up with 79.2, which is a big change. So that's like over, you know, 15, about 15, it is 15 percentage points. And this will show you kind of where it is and how the projection looks. I mean, the previous change was, if you just compared the endpoints, was about 10 percentage points. So this is the trend based on continuation. So doing nothing different, and you may want to be more ambitious with new strategies. So if 4.3% was the average percentage change, maybe you want to increase that to 5%. And you know, you could see what that would be. And this kind of shows how you're kind of bending the curve there to go more than what would be expected. And so whether you bend the curve depends on how confident you are in the projection. So maybe this, yeah, you might want to take it out more years. Maybe this last 5 years was different than the last 10 years. So it's good to really kind of test the sensitivity of your projections and make sure you're confident in them. And then what other factors you have. So your planned reach and knowledge of program effectiveness, for example. Okay, a fixed value consistent with a goal or standard. So again, this is what you all have been using sometimes, is whatever healthy people is. So the healthy people target was 75.8. And that's the target that you could use in your state, assuming that you hadn't already reached it. Otherwise, you could apply their same method that they used, and I'll show examples of that too. So if it was a 10% improvement, you could have applied that 10% improvement. So here's absolute or relative percentage changes. So this 10% was kind of the default for Healthy People 2020. And so here's just some kind of the example calculations for an absolute percentage point change. So that's just the simple addition of 10. And then the relative percentage. So, you know, 1 plus the percentage. So 1.10, and what that corresponds to. And because this is maybe for the Title V example, and it's just 5 years, maybe you would want to have that and just do a 5% change. And so those are the different options if you wanted to make it specific to the number of years. So these are easy and simple. It's why that was a default method for Healthy People. But there are certain caveats here to be aware of. So the absolute percentage points can really only be used for percentage measures, obviously. I think if you were doing a rate, you could do it in whatever units you had. But usually for rates, you would go with the relative percentage, which makes more sense there. So if you had the relative percentage for a percentage, it's a lot more achievable at the lower end. So 10% of 10% is 1%, but 10% of 90% is 9%. And so if this was the same measure and you just flipped it from showing it in a positive or negative terms, you would have a very different target. So that's kind of why you tend to want to use more of those absolute percentage points for a percentage-based measure. Statistically significant change. So you basically determine what would be the minimum statistically significant result. So if you have your Z value of 1.96, you can set what that target would be and your baseline with your baseline standard error. So here that would be 1.96 times the 64.2, which is your baseline. Or sorry, what is this? 2.2. Now I'm confusing myself. I think that's the standard error. So that's plus or minus the baseline estimate of the 1.96 times the standard error. So getting beyond that upper confidence interval limit is 68.5. So what are some problems with this approach? Anybody want to chime in here? Okay. Nicole said this is not appropriate for data that aren't normally distributed. That's true. You probably could figure out a different way to calculate that if it wasn't normally distributed. Statistically significant doesn't always equal clinically meaningful. So that's very true. So it really depends on kind of what data you're using. If you're sampling, you're going to have larger standard errors. And that will be usually a larger difference. If you're using like vital records data, where you would have population-based data, very small standard errors, that's where you would see like very small differences, and it would be kind of like the equivalent of dust, like 0.1 or 0.2 sometimes of a change. And so it's not really that ambitious. So it's heavily dependent on your data source. But we will talk about this a little bit more in subsequent slides because it does have a place. At the end of your performance measurement, you want to be able to say that you had a significant difference, that it wasn't just random variation or within the realm of basically not being able to reject the null hypothesis of no difference. Here's the approach on stratification. It could be, based on geography, poverty, race, ethnicity, for example. So you could, here's some racial ethnic groups, and you could go with the target of the best strata here, which is 69.8. You could also set a target with greater improvement objectives to reduce the disparity. So maybe a 10% improvement, like a larger percentage improvement for certain groups who have more more room for improvement and to get to equity. And sometimes that's also known as like better than the best you could do. So it means that all groups are improving, but some groups would be improving at a larger pace to get to that level. Anyone want to comment on possible problems with this approach? I think it really is, hard to choose like which demographic stratifier you'd go with. And sometimes that group that has the lowest rate, then you're showing an improvement objective for them, and it may be really unrealistic over the time frame that you have. So these are some of the issues that you have to consider when looking at this as an approach. But I have seen that HOPE initiative that I talked about earlier, did use this, and how they did it was they were primarily interested in race and class. And so they looked at those two stratifiers, and then looked at the group within all of those strata that had the best outcomes, and kind of used that to set some targets. Okay. Oh, that's a good one. Ibitola said sample size can limit stratification. And in fact, I think that was an issue for that HOPE initiative. So they weren't able to include kind of all racial ethnic groups, for example. It may not be that reliable, some of the rates. That's definitely an issue you'd want to look into. Thank you. So here's the different options from all these approaches. Does anyone want to chime in and offer what they would choose for this indicator and why? There's no right answer. So it really kind of depends on your context and the decision tree that you may have decided in your program.
Ashley, it's Pat. Can I ask a question?
Yeah, I didn't know you were on.
Yes, I am. I wouldn't miss this. So when you did the stratified indicators in your last slide by race, I'm just wondering about that from a health equity perspective. Should we have different goals for different groups? Should we have one goal? If we had one goal for all groups, it may mean that more resources have to go to some groups to get them there. I'm just wondering what your thoughts are from an health equity perspective.
Yeah, I think that that's a really good point. And the one approach was to have everyone at the same level. That's like better than the best. And that certainly does imply, I think, that there would be a need for more resources in those groups that had more room for improvement. I think one way of setting this overall target wouldn't be to, like you said, not having the same overall objective for every group, but having different objectives. And that's something that I don't think Healthy People has ever done. Having different actual objectives means that you haven't achieved equity. There would still be a difference, but maybe you wanted to get to a realistic level of progress. And I think that's where this bullet was talking about, like having, setting 10% for some groups and maybe 5% for others. And then if you population weight them, then you can get what that would be at an overall population level for a global target. But yeah, I think that there's going to be a lot more conversations on equity, and I have a few slides at the end to talk about that. What would do you have any thoughts on how to really incorporate this better? I feel like Healthy People has never really addressed this well. So if you look at many of the targets, there are groups that have already met it at the outset of the decade, and other groups that have never met Healthy People targets. So it's definitely an area that needs more attention.
Yeah, I think to that. Oh no, you finish, please.
Oh, just that is like health equity measurement. That's something how we'll talk about it. Like I said, later, almost near the end. But it's definitely something that the Bureau is interested in. I think we have a research network on health equity now, and kind of how to harmonize measurement. There have been calls in the field to harmonize that. There's so many different ways to measure disparities. And I think it would be helpful to kind of settle on one and maybe help to implement that to get to equity. Because right now, what we're doing, I don't think is helping us get to equity.
Yeah, I think the fact that Healthy People hasn't actually dealt with health equity, I think is telling, and that we should be doing that. I think we're in a time where we are thinking about the need to provide more resources to certain groups, because the usual approach means that they fall further behind because we haven't made enough progress on equity. So I would like to support different ways of calling attention to the need for different resources, whether it's, as you said, different objectives, or in order to achieve the goal, having more resources go to certain groups. I think these are all important discussions that we should be having, and using our data and our measurements as ways of supporting those conversations.
That's a great point. Thanks, Pat. Yeah, if anybody wants to mention with this example kind of what they felt most comfortable with, I'll pause for a minute for this objective. No one's feeling too strongly, I think. Trend analysis, okay. And that is actually more of the scientific data-driven route to forming objectives. So that's actually the direction for sure that Healthy People has taken. So let's look at that. Here's a couple of slides on setting interim year targets that you'd have to do for Title V. So once you have your long-term or 5-year objective, you kind of have to work backwards to get your interim year estimates. And this is the way you would kind of calculate that, the per year change. So the overall difference divided by the number of years you're changing, and then for the relative percent change per year is your target over your baseline, and take into the power of 1 over the number of years changing. So the next slide kind of shows that if they had chosen 75.8 for their 5-year target, these are what the annual absolute and relative percentage changes for those 5-year objectives would be. So here's just the calculations. You've got 5 years and the absolute difference. So that translates to 2.32 percentage points per year. If you did it on the relative scale, those are the numbers plugged in there. And that is 3.37% per year. And then the next slide is kind of a check-in if you wanted to calculate what that would mean for the year 2 target. So if you had the baseline and you had the annual absolute change of 2.32, what's the year 2 target? And you can just type that into the chat. Anyone? Help me out here. Okay, thank you, Jessica. That's exactly right. 68.8. So it's just, the two years of change multiplied by what that change is. So very simple. And then the relative. Just this at 70.9. That's not quite what I got. So it's just, the relative percentage change twice. So kind of you multiply it once to get the first year, and then by another 1.0337 for the next year, and that's just the squaring, so the number of years. So it's a little bit less than the absolute. I think it's really a personal preference, whether you would want to have more of that curvature of the absolute in setting your interim targets, or just doing the absolute change. And it may depend on how you did your projection as well, if that was the route that you took. Okay. So here's some applied examples with healthy people. So these slides are kind of showing the evolution in kind of the learning curve for healthy people. So in Healthy People 2010, 44% objectives used better than the best by race ethnicity, and 23% of objectives with data met the target. They determined that if 10% improvement had been used, about 50% of targets would have been met. So basically, that better than the best methodology was kind of not achievable for most objectives. So they wanted to kind of revise the approach and kind of look at a more realistic, systematic, and transparent approach. For 2020, they had a recommended approach, which was the modeling, projection, trend analysis, and the standard default of 10%, and then some of these alternative and other measures. And you can see that most shows that standard default, 10% improvement. And these are all work group areas that had like the ultimate choice on what to select for their targets. And as a result, the percent of targets did improve. That was one of the highest success rates, I guess, in terms of targets met. So the 31.7% was higher than they've had in previous iterations of Healthy People. But I think the real problem was that, fewer than 10% chose that data-driven approach. And so they kind of realized the need of having more of a standard kind of flow chart and decision tree to assist the processes, and have tools available to kind of do those projections. So I think we're all benefiting from that now, and I'll show you. Here's their formal decision tree. So you can see kind of where you would choose different strategies. And that could be helpful as a model for developing a systematic selection process. So as a result, the target setting methods, how it changed for 2030, there was definitely an improvement with projection. So now a quarter of the measures were based on projection. Percentage point improvement was common. Again, they thought they liked the percentage point over the relative percentage for a lot of those measures that were percentage based already. Just so that it had the same meaning regardless of how your measure was framed. And these are some of the target setting examples. So projection, for maternal and infant child health, these are some of the examples. Breastfeeding, they use projection because there was a significant trend. Percentage point improvement was used for developmental screening because they didn't have trend data. And it was a percentage. Relative percent improvement was used for severe maternal morbidity because there was a trend in the wrong direction, and it was a rate. So it's appropriate to use that relative percent improvement. Minimum statistical significance. They use this for early autism services because there wasn't trend data, and the percentage point improvement would not have been statistically significant. So in order to be able to kind of assess whether you've had real improvement, they needed to go beyond the standard percentage point improvements. Consistency with policies and laws. There's an example here of an increased federal and state cigarette tax, and using the U.S. Community Preventive Services Task Force recommendation. So I think it was maybe like getting to 100% that had taxes or a certain level. I think the level was set by the CPST. Maintain baseline. So child immunization is an example where they were already exceeding 90%, which is that critical threshold for herd immunity. So they wanted to maintain that. These are some of the helpful tools that Healthy People 2030 has released, and you can see that website link there. So they have a trend analysis tool that just requires 3 or more data points. It implements, and this is in Excel, so it's really easy. It implements a weighted least squares approach if you have standard errors. So that just kind of weights different observations that you have differently depending on how confident you were. So if you had large standard errors around a certain estimate, it wouldn't receive as much weight. And then ordinary least squares if you don't have the standard error estimates. And then you can choose values from one-sided confidence interval limits to be more or less ambitious. So kind of ranging from 10 to 90%. So they kind of label these as like 10% confident that you would need it, or 90% confident that you would need it. And so that 10% is the more ambitious approach in terms of the confidence limits. If trend data are not available, or there's no trend, or they're trending in the wrong direction, then that decision tree uses an alternate method. So percent improvement and minimal statistical significance has a tool. For rates, they use the standard percent improvement 10 or 20%. And then for percentages, they use effect sizes to overcome that issue with the relative percentage corresponding to different absolute values for percentages. So this effect size approach uses this what's called Cohen's effect size, and that's used to standardize the percentage point increases that correspond to 10%. So that is kind of the 10%. The Cohen 0.1 corresponds to up to about a 5 percentage point change. And then a Cohen effect size of 0.2 is up to a 10% point change from a 50% baseline. And then you can check that against the minimum statistical significance, and maybe go with minimum statistical significance if those values were not high enough to reach that. So lastly, monitoring progress. This is what you all said was the easiest of the phases. So we can maybe go through more quickly, but I think it's helpful to look at the Healthy People guidelines here in terms of categorizing different measures and where you are with them. So they have kind of different criteria for whether you met or exceeded a target. So they use these progress quotient calculations. So it's basically the percent of the target achieved. So what's your current rate, subtracting the baseline, and as a percentage of the total target and change that you had. So how far are you along in meeting that? And so you could have already met it, in which case they would like to see the statistical significance. You could just be improving, so not quite at 100% of the progress quotient, but still significant improvement. Little or no change would be, having a small progress quotient, or no statistically significant change, and then getting worse if you actually had a statistically significant worsening, or a more than 10% change from baseline. So if you were moving away from a target, they just calculate that percentage change from the baseline. Okay. So here's the progress quotient and statistical significance that you could examine. They use a one-sided test because hopefully you're moving in that one direction. And all of these formulas, will be in the slides, but it's part of one of the Healthy People documents that I had a link to earlier. And here's the formulas for moving away from a target. So here's just I think a last calculation. If the year 2 NPM estimate was 67.2, what percentage of the 5-year targeted progress was achieved? So if you want to do that little calculation, let me know how far along they are in their progress. And y'all may be extremely fatigued at this point, but it's pretty simple that the actual difference that you've achieved so far versus the total difference. And so they're about a quarter of the way there already in year 2. That's pretty good. Here's some example progress reports for how you could show it in a tabular form. You could organize them by those that have met the target, improving, so on and so forth. And you can show the baseline, most recent, how much your movement is and if it's statistically significant. This is for Healthy People 20.
Ashley. Hi. Yeah, sorry. I just had a quick question of that calculation 2 slides ago.
Okay.
So did you calculate the baseline first, the 64.2? Like can you just explain how you got the baseline there?
That's what we've been working through in this example, but.
Okay, sorry. It wasn't on that slide there. So that was,
exactly.
Just wanted to confirm. Thank you.
Put that in there. You needed all of the inputs in that slide.
No, it's okay. I just wasn't sure if somehow it was calculated from this slide, but I appreciate it. I just didn't realize it had carried over. Thank you.
Mm-hmm. Okay. So here's what Healthy People 2020, you can kind of look at Their graphs and table forms. This is a pretty handy tool you can look at by their objective area, look at, whether their final status was improved or target met. And you can see that overall, that's the same that we looked at before. Overall, 38% of the targets were met or exceeded, and another 22% were improving. So that's over half. Fairly good. And then here is where they look at the differences by the strata, the demographic strata. And to Pat's point earlier, you can really see how the groups that were better off to start with were more likely to meet or improve their targets. And so we're not doing really anything to close the gaps, sadly. And that's why I think we do need a different approach to help achieve that. This is just a quick resource if you are in a state looking at Title V data. We do have this resource document that includes an analysis tab this year. So for all of the measures, you could select your state and look at all of the measures and see over time a little run chart and whether that change was statistically significant. So here, this is Alaska, and they had those in green were improvements, significant improvements, and in red are significant decreases. So this is a really helpful tool. It also compares your rankings, state rankings, which are often used for needs assessment, but also possibly to track progress. For example, if the overall trend was down, but your state didn't go down as far, your ranking might have improved. And so you can kind of look at the ranking there too. So integrating equity, these are the last couple of slides. This can be monitored or used as an actual performance measure with objectives. And I think that that's kind of where we need to go if we're serious about achieving equity, is not just to monitor it like Healthy People does, but to create an actual performance measure. And we do have a performance measure for the block grant overall for our congressional reporting it's just a standard measure that's been in existence for a long time. But the Black-White infant mortality ratio is tracked, and unfortunately we're not going in the right direction there. And so just because you have a measure doesn't mean you make progress. You have to put in the effort and the meaningful strategies to achieve that. Global, or you could do a global measure. So I've seen some states do that where they're looking at disparities for all of their measures and then doing kind of a roll up. So tracking like the percent of all measures that show an improvement in equity. You could do some kind of roll up measure there. And there are a variety of approaches. There can be pairwise comparisons. So like that Black-White, you have certain groups of interest, or summary where you look at all of the groups, different scales, relative absolute, different choices of reference groups, and whether you decide to weight or not weight by population size. And this is where it really would disadvantage small population groups like indigenous populations that have smaller numbers. If you kind of weighted by population size, they would have small numbers and wouldn't receive as much weight and priority. So there's definitely like implicit value statements from some of these options. So this is an example from Healthy People and the measures that they use. and I will look at Jessica's comment too here. As we look towards equity, we've been avoiding it as we don't want white to be the standard. That's a good observation. And I have kind of seen in the literature where basically you just need to justify your group and make sure that you're not saying that this is the best or the ideal normative group. It just, you can kind of make sure that you're explicit about saying that if you use the white population, that you're using them because they have had the most historical advantages in the country. So that is, I think, an acceptable approach to still use white as a reference because of that historical advantage and disadvantage for other groups. There are definitely different approaches, but that's one option, as long as you're explicit and not, if you don't actually say that, then you can be reinforcing these kind of standard best group value statements. So here is some examples of where they did the absolute and pairwise relative disparity. So the absolute was the largest difference between groups here. And that was 8.8. So it was non-Hispanic, Black, and Asian. That was the largest difference. And then the pairwise relative disparity is 2.9 times the best group. So just dividing. And then the average rate for all, excluding the best, that's kind of a summary measure. So you take the average for all of the other groups, non-Asian, that was the largest question. Or the largest, the lowest, that was the reference. And it's 1.82 is the summary rate ratio. And then if you look over time, that this is what happened. Oh gosh, I'm sorry, we're a little bit over. In terms of these different measures, absolute, relative, summary rate ratio. And you can see that the changes over time, it definitely differed by the different approach that you took. So the maximal rate ratio and the maximal rate difference improved, but the summary rate ratio showed a slight increase in the disparity. And you'd want to look at statistical significance here. So the takeaways here are, obviously measuring health disparities are complex and there's different measures and can lead to different conclusions and changes over time. Some recommendations are to use consistent language and methodology that can be referenced and verified and take advantage of established methods and references. Here are some key references that are helpful. This implicit value judgments and the measurement of health inequities or inequalities, and an NCHS report on methodological issues in measuring health disparities. So it's just the last take-home messages that a performance measurement involves the selection development of indicators that flow from agency priorities for improvement. Really may be helpful to look at that 3M criteria, meaningful, measurable, movable. And different types of indicators can capture both outcomes and strategies, those processes and outcomes. Targeting setting depends on many variables, but you generally want to seek achievable stretch goals. And then tracking progress is a first step that should be formally connected to program evaluation to really be able to identify successful practices and help aid improvement. So I think we are over. I did want to acknowledge Allison had Yeah, so the same kind of question, why it's always used. And so I think that that's the reason sometimes it has been used because it's the largest population, but that doesn't mean you want to imply that it's the best rate. It often isn't, but I think it's because of the recognizing the historical advantages for the white population in this country is kind of why it may still be used. Okay, great. I guess I can stay on a little bit longer if you want, but I don't know how many people are still on. But feel free to contact me. Happy to continue the conversation. Yeah, there are still 40 people. Thank you all for hanging in.
Thank you, Ashley, and thanks for taking out time from your busy schedule and day, and thanks everyone for joining us. The recording and evaluation will be headed your way likely this evening, maybe tomorrow morning, depending on upload speed tonight. And then we hope that you can join us back in a little less than a half hour for a roundtable discussion on social determinants of health. It'll be informal, just come as you are, bring a snack and a refreshing drink, and just have conversation with the faculty and each other on that topic. Again, thank you, Ashley. Mike, do you have anything?
No, other than to say thank you, Ashley.
Of course, happy to be here and try to help support work and learn from you. If you guys have all some good examples of your own work, and we definitely want to hear them and integrate them. And actually that's the federal state partnership that is Title V. So that analysis tab that I showed you that looked at improvement over time and statistical significance, that actually came from a report that South Dakota had done. And we thought it looked really nice and wanted to try to integrate some of that more formally. And it will, we hope, will be part of the actual block grant report to make it easier to see progress over time. I see Mike nodding his head because he's a frequent reviewer, and it would really help both the state and reviewers immensely to have it like right in there as you're reviewing different domains. So that's continuous quality improvement and sharing. What is it? Share seamlessly, steal shamelessly. So yeah, please let us know if you have some like great examples with equity maybe you're doing in your state. I would love to hear more of those.